morning. Thank you very much for the invitation and for giving me the opportunity to discuss with a person that needs no introduction. I believe that you are all aware of his CV. Mr. Mossialos serves in a position in an advantageous observatory of international developments in the health sector, in the global health-related problems, health systems and how they evolve. There are many different things that I want to talk about with Mr. Mossialos. That is why I would like to speed up in order to observe the time. And Mr. Mossialos, thank you very much for being here. It is a great pleasure to be given this opportunity to discuss with you. And I would like to start with the big picture. If we had to identify which are the biggest challenges pertaining to the health systems, the first thing that would spring to mind, at least for our societies, is the demographic problem, the aging of the population, meaning that the health systems will have to deal with the problems of a population that is aging, where the seniors constitute a larger part of the population. Is this a problem? Are there any other ones? Yes, this is probably one of the most important problems that we're faced with globally. It is not just a problem of Greece. I believe that you are all aware of the statistical data of our country. We are the third worst country in terms of the percentage of people over the age of 75, second with regard to the target group of over 80. And maybe actually this could be seen differently, that we have these many seniors, and this means that we live longer. So this is a good thing in a sense. But we don't have a lot of young people to support these over 65 or over 80 years of age. And of course, this impacts not only the health system, but also the pension system. There are more pressures that we can actually see in other countries. In France, for example, we have seen that President Macron wishes to extend the retirement age until 62. And of course, we know that the retirement age is associated with life expectancy, and this is quite understandable. If we live longer, we need to work longer so as to ensure the sustainability of the pension systems. However, the country that will face the biggest problem is China. In the coming 30 years, the Chinese population will be reduced by 30%. In the coming 50 years, based on the estimates, it will be reduced by 50%. Based on the policy of one child implemented by China during the last 30, 40 years, there will be an enormous problem to sustain the elderly because they don't have a system for long-term care. And there are not many families that have two children in order to support the parents and the elderly. Apart from the elderly related problems, there are the problems associated with comorbidities. We have many possibilities of developing comorbidities as you age. This is understandable, but at the same time, you may die because of these diseases. The health care is not enough to keep us alive until 90 or 80 years of age. And this is exactly what the ministers of health and the prime ministers need to focus on. The feeling is that a health system caters to the elderly. This is a wrong view. We're talking about health for all. If we take a look at the number of those who have comorbidities in the total of the population, we see that 80% is a working population and the rest pensioners. So this is an argument that we need to use more when we have discussions with the political leaderships. And another major problem is climate crisis. We no longer talk about climate change, but about climate crisis that will cause a lot of respiratory problems and cardiovascular problems. And there is the fourth major problem, the migration flows. The big migration flows that will be a result of a climate crisis are not the ones that we currently see. What we currently see is the peak of the iceberg. Those who arrive in Greece and in Italy constitute less than 1% of those who are moving inside the country. And of course, it is not that important to focus on what are those that are moving inside Europe, but to see which are the ones that move from the regions of India to the major cities of India. There will be major flows. The same will stand in China. 250 million will move from the regions to the major Chinese cities. The same will happen in Nigeria. So what does this mean in terms of health? Mumbai will become a city, 40 million inhabitants. This, of course, will be a very explosive mix for the life of people, and there are a lot of chances for a next pandemic to occur. Yes, we have talked about the previous pandemic with you quite a lot of times, and I wanted to ask you whether you are expecting a next pandemic and what kind of a pandemic will it be. We don't know exactly, but the conditions that are created because of the migration flows and the climate change are favorable for a next pandemic. We know that there will be a pandemic. Actually, there is a pandemic that is currently underway, and this is associated with the microbial resistance. And do you think that we are in a worse situation here in Greece compared to the European average? We are champions. Of course, I'm glad for the fact that the minister uses objective data. But when it comes to microbial resistance, we are #1 country in Europe. And this is something that the ministry should focus on. See, in other words, how from being champions in deaths, we can converge to the European average. Of course, I cannot claim that we can be Sweden of the South, but at least we can come closer to the European average and reduce the number of deaths. This is a major problem. Okay, and how can we do that? By taking measures to deal with the multitude of drugs, and especially antibiotics. We know that up until recently in our country, one could take antibiotics without any prescription. Fortunately, this phenomenon has shrinked. Still, we have a lot of antibiotics being prescribed here in Greece. During the crisis, when the pharmaceutical expenditure was heavily impacted, the consumption of antibiotics was not reduced. And this was impressive. One would expect the opposite. The pharma expenditure was reduced, but not the consumption of antibiotics. Yes. On the contrary, actually, the consumption increased. If we take a look at the IQVIA data, we will see that clearly. So what is needed is an intervention in order to minimize consumption. There are hospital programs also. One is being implemented by the Ministry of Health along with the Stavros Niarchos Foundation. Needs to be more intensified. And of course, we need some new antibiotics. The pharma industry is not investing in these. Why? Because we may need antibiotics, but we shouldn't use them. So when we ask a pharma industry to produce a product that we will not use, it's like we deprive the pharma industry of an incentive. So the old antibiotics are no longer performant. Yes, most of them are not performant. We will definitely need 10, 15 new antibiotics in the coming 20 years. And in order to find these 10, 15 antibiotics, we need some bold partnerships between private and public sector. In the previous panel, we said what the European Union must do. The European Union must be in the front line when it comes to PPPs. This means that the public sector will subsidize large part of research and development on antibiotics. And at the same time, it will create markets. What do I mean by that? It will buy quantities of antibiotics that will not be manufactured or consumed here. In other words, it will get a share if pharma industry produces the antibiotics and consume them in case of emergency. If I were a shareholder in the pharma industry, I would not exercise any pressure on the board of directors to produce antibiotics, since the profit that the companies get from oncological products is huge. Just like we did with the vaccines, because with the vaccines, you remember, they were the result of a PPP. World Speed operation that started in the USA. And okay, we may say a lot about President Trump, but he did one good thing. He was one of the first, along with the European Union. And of course, I do not underestimate the speed at which European Union operates. So Trump, Great Britain and European Union co-funded the production of new vaccines. There was this fast state intervention. If there wasn't, we wouldn't have these vaccines. You mean back in 2020? Yes, back in 2020. These three parties funded the production of vaccines. Trump, Moderna and Pfizer, and Great Britain AstraZeneca. Without these guarantees of prices and purchasing of large quantities of vaccines, we wouldn't have this speed in the production of vaccines. So we need to do the same thing with antibiotics and with anything that we perceive as public goods, including vaccines, of course. I don't want to turn this discussion into a very political one. I hear what you're saying, but what it means exactly. The fact that the Minister of Health of the United States is a person who was in the front line of the campaign against vaccines, launching a very aggressive campaign on the social media in order to prevent people from being vaccinated. What does this mean? It's a paradox. The president that assigned him in this position was the one that actually contributed to the development of these vaccines. So I believe that President Trump needs to be credited with bold actions while he was president. He moved fast. Now, about Mr. Kennedy, what can I say? I don't want to comment. He changes views very often, as you know. Even though the cause of autism were vaccines against smallpox, all of a sudden now the cause is paracetamol. But we need to wait and see how things will evolve. My personal view is that realism will prevail in the American policy in the coming years. After they try different solutions to see what works or not, rationalism will prevail even in the health sector.
Now, you described 3 or 4 large global ecumenical challenges for the healthcare systems and health policies. The greatest challenge for the people, the latest one, that was the COVID challenge, was dealt with thanks to the intervention of government states such as the US, the UK, and the EU, but also through the coordination of all international organizations, such as the WHO. It played a role that very quickly gave the understanding that we have a pandemic. What we see now is that these international organizations weaken significantly. So I wonder what we can do to keep them alive. Now, these do not weaken, and we have people who are leaving. I mean, the US government left the WHO. They still haven't left other international organizations that have to do with health-related issues. Argentina also left the WHO, but not yet from the Pan-American Health Organization that belongs to the WHO, which is a bit weird. So after that, we have a fragmentation of international organizations. And if we see how many organizations we have, apart from WHO, we have the Global Fund that deals primarily with malaria, tuberculosis, and AIDS. We have Gavi, which is about antibiotics. We have UNAID, that is for the developing countries. We have SETI, that is on the production of new vaccines. We have the World Bank that works and operates the pandemic fund. It is a $10 billion fund that will subsidize countries to become more resilient against the next pandemic. We have the IMF that imposes fiscal restrictions on all the planet. And there is no coordination among these organizations. And the discussion must open as to what sort of organizations we need and whether we need so many. Do we need a better WHO? Will the WHO be the one that will secure global goods? What do I consider global goods? Is the production of antibiotics, production of vaccines, synthesis of the knowledge we have as to what works and what doesn't in the health systems, and creation and drafting of guidelines? Or should we have a WHO that has offices in 150 out of the 193 countries of the world and supposedly advises governments as to what they must do on the healthcare systems. Would it be better for the WHO to focus on the global matters rather than interfere in the internal matters of countries and give advice whenever these member states heed that advice? I would rather have a smaller WHO, concentration of all these organizations under a single umbrella, and of course focus on the big problems: climate change, global goods, production of vaccines and antibiotics, and that's it. And guidelines, nothing more. Unfortunately, Mr. Tedros, which is in charge of the WHO, and others who are in charge of the other international organizations haven't found the time yet. And it's been 9 months since Mr. Trump said that they are leaving the WHO. They haven't had time to discuss on what they must do. It's as though they're denying the global reality changes, and it doesn't change only for the US. Norway, the Netherlands, the UK, Germany, Denmark said that they will halve the aid programs. It's not just the United States, and at the same time, they relate these third world country aid with their foreign policies. And this says a lot. The global scenery changes dramatically. The global organizations haven't come to terms with that, haven't realized it. So we need a big debate as to what sort of international organizations we need to protect us, not just do policy. Now, before closing this ecumenical, global and universal problems that is these international organizations, let's say a few words about China. Yes? Okay, because, well, I wasn't aware of the data you mentioned, where China is going with the aging population it has, but China is a very important player in the production of health policies as well, and health-related products. To give you an example, in 1995, in the global allocation of health expenses, 37% of the world, if we spend $100 all over the world, $37 were spent by the States and 26 by the EU. China was down to $3 per year, although it had many times the population of the United States and the EU. Now the US is down to one-third, $33 spent in the US, 20 in the EU, 15 in China. Over 20 years, what is predicted for the next 10 years is that China will surpass the EU in the global health expenditure, and it's very important for you regarding the investments that your companies will make, and you're already making big investments. So one-third of the new drugs is produced in China. It's much easier to have the procedures done in China for the production of new drugs, because these processes and these procedures for clinical trials, I don't want to say anything and have a quarrel with the Chinese embassy with the US government, is much easier to do in China. In Europe, we're still discussing on whether we'll be using animals in the first stages to see whether the drugs are safe. In China, these things are outdated. For better or for worse, it's a reality. So there will be a boom of treatment interventions that will be to the benefits of the global community. And this is a positive thing, not a negative one. It's not by accident that large American and European companies are forming consortia with Chinese companies. But there's another thing. We're talking about a country that's 1.4 billion, 130 million hospitalizations every year, 130 million hospitalizations every year. In our country, it's approximately 1.2 million, okay? 1.2 versus 130, and 8 billion transactions in the healthcare system out of hospital, access to primary health care. 8 billion per year? Yes, 8 billion per year. And this means a huge volume of data that China is trying to put in order and make it systematic. And Europe is afraid, which is why we're moving into the single European health data space. That if we manage to have a single data community in Europe, we will have 450 million approximately inhabitants of the EU in a single system. If we take into consideration the countries under accession, including Turkey, which is populous, it may be 600 million. With the English, the UK, it will be 670 million. It's not negligible, okay? But we still have a long way to go in the unification of these systems, and Europe must move very, very fast, and we are not. China has very simplified procedures and a single management center without democratic procedures. Under such regimes, the collection of data and their processing is much more unimpeded. It's a bit scary, isn't it? Yes, it is quite. Now, given the opportunity, where are we in terms of data? I mean, Greece, okay? Well, we as a country have an advantage. we have 98% of the population covered by a single insurance fund, social security fund. It's the AOP. There are some exceptions, like yours, the journalists, the banking staff. Well, we are like the Asterix village. We are not yet under the Roman Empire. But we are all under the AOP, a single insurance fund. And this creates, with IDIKA, which is a company belonging to the wider public sector, it creates a possibility and capability to gather a tremendous amount of data. Unfortunately, we didn't put it to good enough use during the pandemic. We had the data, we could have found the efficacy of the vaccines in Greece had we done better management of the data. There are a lot of problems of data management and use in our country, and Mr. Georgiadis could simplify them. The best studies on the studies came from Israel and Qatar, two very small countries. Israel has 4 insurance funds, and they came from one. We had the Klalit. And Klalit has a think tank of 100 people who process data, okay, real time on a daily basis. We do not. Yet, how to do the interconnection of the data between IDIKA and AOP with the research centers of the country, the universities, and other research centers is something that needs to be seen. Second, we must have a biobank. Everyone's talking about the biobank. It's something I raised in the public debate over the past 10 years. And it started back in the UK. There aren't many countries that do have a biobank, which is why we have a window of opportunity. The UK does. It has 500,000 people, and Abu Dhabi follows that has almost all, except 50 or 60,000 people in the biobank. It's a more complete and integrated biobank in Abu Dhabi than the one with England, because in England it's not even a random sample that they gather. Abu Dhabi links its biobank with the IDIKA of the rest of the Abu Dhabi, so the use of the services. We could do something similar. Okay, we're not a big country. All it takes is a bit of vision, I would say. Okay, let's not stick just to the internal things that we painted a coat of paint on the outpatients ward, or we made some reforms in the health system. These are useful things and need to be done. But if we are to move on to the next level, a biobank is necessary. Give us an example. For instance, the ladies and the gentlemen who are here understand this automatically, but I would like an example that will help me understand what is to gain if we did that. Well, everyone is talking about individualized or personalized, tailor-made healthcare without having what we need. It has limitations. It needs connection with the genetic data and the environmental data, where we live, under which circumstances, the use of services to see whether they're linked there, whether some drugs work for some people and don't for others. It will give us valuable information. This is genetic material, what we're talking about. And then behavioral data. If some citizens accept their behavioral data, how many steps they take per day. Or whether they smoke, what their biometric data are, whether they gain weight, lose weight. The complexity of those data, if introduced in a single system, can bring the country in a much advantageous position, because in 5 years from now, more countries will enter the field of unification of data. So it is a proposal to the political leaderships of the Ministry of Health of Greece and Cyprus alike, is to set as a priority the national policy on data. Okay, private data. It means to be the same for the public and the private sector. We have the private sector data in IDIKA, but what the public sector reimburses. If I go to the private sector and use something, or I pay out of pocket, or the insurance company does, they're not included in the IDIKA system. But this is something that a legislative regulation may resolve it. I mean, a private hospital or a private doctor does not want to share the data, they will not have contracts with the public sector. It's simple. Now, the big challenge is to move on to the next part, is artificial intelligence. Okay, we read a lot as to how artificial intelligence will change medicine, will change diagnosis, it will change pharmacology, it will change everything. I don't know how much of that you believe is too much, if it's science fiction, if it's Jules Verne, or whether it's reality, and how much it will actually affect everything. If its program would create a medical school for the next 6 years, for the students that will be introduced next year, and has to put it together, taking into consideration the changes brought about by the AI, what do we need? Well, first of all, AI, but everything that is around that, and I'm talking about the sciences that support AI, which is statistics, biostatistics, epidemiology, methodology of research, will now have to be included in the main curriculum of medical schools, and not only medical schools, dental schools, pharmacology schools, and nursing schools alike. At the moment, we don't have it. When I studied medicine, a long time away, epidemiology and biostatistics were like breaking rocks. Okay, it was like forced labor. We had to do it, but it wasn't something that enthused anyone. Now, how we will use AI without knowing methodology of study, analysis of data, interpretation of data, epidemiology and biostatistics is beyond me. It's very easy to ask ChatGPT questions and get answers, but you must be in a position to interpret and explain the responses you get from ChatGPT. The fact that AI systems will improve is a fact. We're not yet at that big hype that it will solve all problems. And those who are more into AI know that there are many illusions or hallucinations, as we call them. In ChatGPT, you know that does not give you references that are reliable, okay? Bibliography, literature. Many of the information need to be rechecked, fact-checked. And if you ask a simple question, ask ChatGPT something, and then repeat the question. I do this often. Are you certain that the answer you gave me is the correct one? It will correct the answer it gave. If you challenge it a little. We're publishing a study shortly that we asked GPT questions in 4 different parts of the country: Australia, Canada, England, and the US, using linguists to have the exact same question in English, because it's not the same English in all 4 countries. So we got different answers in the 4 English-speaking countries, with the more reliable being the ones given to the US colleagues. Our American colleagues received more reliable answers than what the New Zealanders, Australians, and the Brits did. Is it because the population communicated is more? Well, I don't know how they do it, but ask them to give us answers how they will cure a simple hypertensive diabetes is and what it will do. But artificial intelligence synthesizes what it can find on the internet right now. In the best scenario, it will synthesize guidelines, data from guidelines, the guidelines that the doctors themselves, the medical associations, and medical societies produce themselves. Guidelines are not the same in the US, in Japan, China, or England, and in various parts of the country. So it will perform a synthesis in the way the algorithm dictates it to. If this algorithm is not put together correctly, the answer will be on the one that the algorithm will prefer. I'll open a parenthesis here to say that the guidelines are the best. Are the guidelines the best thing we can find on the planet? Well, in my opinion, guidelines are there to protect us as patients from mediocre healthcare professionals. This is why we have guidelines. Experienced doctors and good doctors are there to protect us from guidelines. Okay. So we'll need to think how we can make the transition to AI systems that can synthesize information that will be based on the experience and knowledge of medicine, not the way it is synthesized in the way to protect us from mediocre cases.
I imagine there are other doctors. I know at least one that is in the audience. There is a discussion taking place about the way that AI and other technologies will change the doctors we need and the specialties we need. Yes, and this discussion should be taking place in our country and elsewhere, because currently we don't have this discussion. But I would like to give you an example about our country. We have more plastic surgeons or oncologists in Greece. What do you think? We are the country of beauty, aren't we? A nation of proud and beautiful people. We have more plastic surgeons than oncologists. Moreover, we have more ophthalmologists than oncologists. Is this unreasonable? This is the current state of affairs. Should it change? Already, the Council of Health should start taking into account the different health problems of the population in order to make the necessary changes, because you understand that changes need time. Time is also needed to change the curriculum in the different schools. We need these changes in order to have the oncologists and the general surgeons that we need. Of course, I understand that surgeons is not something that most doctors want to become. It's not one of the most popular choice. But we need to make sure that they will be more in the future, just like the practitioners in general medicine. Some part of the medicine will inevitably shift towards AI, anything that has to do with images. For example, X-ray diagnostics will be something that the AI will do very well. And so the doctors will do some other tasks. In anatomy, in internal medicine, again, we will have the use of AI. The internal doctors, however, will focus on some other more important tasks. The fact is, however, that we need other specialties of doctors in the coming years, and we need to start discussing about these specialties. Okay, we have many representatives of the pharma industry, and that's why I would like to ask you. We have progress made in pharmacology. We have new drugs being produced. For example, the new drugs for obesity that set some dilemmas. For example, will we prescribe these drugs for people who are truly obese and suffer from obesity, or will be available to the wider population? Look, this is a huge dilemma because it means that the whole health rationale will have to change. Up until now, there were specific methods for obese people to deal with their disease. Now there may be a change, and I believe that the use of these drugs will expand, and our country will rightly finance these drugs for people who have BMI over 40. And basically, in Greece, we do what the British or the Swedish are doing. But I believe that this should change gradually. We need to drop the BMI index a little bit, even though, in my view, BMI is not the most credible indicator. The most credible and reliable indicator is to measure the percentage of fat in our body and where it is concentrated. This will allow us to have very valuable information and data. And it is easy to be done. But, okay, for the time being, we are doing what we're doing, and it's okay. But we need to drop the BMI, because if we don't, then a large percentage of our fellow citizens will not have access to this type of drugs that are very innovative. And, of course, that can be used in order to deal with many types of cancers, since we know that obesity is associated with 16 types of cancer. Maybe these drugs will have a positive impact on renal failure, on cardiac diseases. So we need to have this discussion, and maybe you should think, we can come up with a healthcare solution so as to reduce the limit for the use and expansion of these drugs. If I have one more minute, and since, of course, we will have some discussions about the NHS and its problems, now I would like to ask you about the British NHS. It was the model on which the NHS of Greece was based. So could you elaborate on the problems that the NHS is faced with? Because maybe we can get some ideas on what we need to do here. There is this belief that the Greek NHS was based on the model of the British NHS. I want to tell you that we got a single insurance fund during the memoranda. You remember that in the past, the President of the Parliament, Mr. Alevras, actually voted against this initiative to establish a single fund. And we also opposed the promotion of primary health care. That was something that Britain was doing very well. Now, Britain has lower public health expenditure. However, it is a country with huge inequalities. Why am I saying that? Because the NHS cannot resolve the problems of inequality. The NHS absorbs the problems of other systems, like the educational system, the environmental problems, the poverty rate. We know that Britain has one of the highest poverty rates, children's poverty rates in Europe. Housing problem, where people live, long-term care, all of these problems that are societal impact the health system. The British population is far sicker than the Greek population. The NHS there is under enormous stress. And of course, on top of that, there was Brexit. They lost a large percentage of the medical and nursing workforce, and now they are under enormous pressure. There are also some political mistakes that were made. The government of the Labour Party during the last 15 months has published the report of Lord Archie, my colleague in the Imperial College, saying how bad the previous governments were. Now they published a new plan for the coming 10 years of the NHS, which is a good thing. However, it's quite general, and we don't know when they will publish the operational plan. And we will soon reach the 2 years of government of the Labour Party, and we are still discussing what needs to be done. I believe that Britain has lost sight of what it needs to do to promote and protect the NHS. We keep on reading a lot about the British NHS, about cases that are encouraging, others that are not. Britain is a country that measures everything. And I want to know as a person, just like I do in Britain, how many people die when they suffer a heart attack. In Britain, they know the number. But I also want to know how many people die 30 days after they were hospitalized. And why am I saying 30 days? Because those who are managing the hospitals may come up with policies to prevent the recording of deaths after the 30 days so as to prevent people from getting hospitalized. So British do record all these cases and all this information. And here, I would like to see something being done in terms of data collection, real data collection. I want to know whether the health level will be improved once I'm hospitalized. We need to know this. And I'm also very interested in knowing whether after I suffer a stroke or a heart attack or cancer or what have you, whether I will be released from the hospital being in a better state or not. These are the data that we need to collect in our country. We have the opportunity through Ithika and through the know-how that we currently have to do this. The English do it, and that is why we hear about all these negative cases. But the purpose of data collection is not to penalize the health system, but to improve it. Not to blame the doctors for everything that happens, but to identify what is not working well, because many of the problems that we are talking about are system-related, and we can improve them. So I would like to end on a positive note. I believe that we can do all of these things here in Greece. In Greece, thanks to the centralization of the system, we can get good quality data. We need to have vision. In other words, we need to think about what will happen 5 years later. I'm also in favor of PPPs on the condition, of course, that transparency is the basis. If we agree on that, and if we agree that PPPs can help us evolve, then yes, we can make the next step. Thank you, Mr. Mossialos. Thank you for your attention. I apologize for taking your time. I hope that you found the discussion as interesting as I did.